Welcome. We're going to ask as you log in if you're able to mute yourselves. We're going to get going in just a minute. Okay, I think we're good to go. So welcome everyone to our third Thursday Community Engagement Speaker Series. Tonight we have our topic, Integrating Community Input into Policy, Practice, and Research to Advance Equity in Boston. Our guest panelists this evening are Dr. Bisola Ojikutu, the Executive Director of the Boston Public Health Commission. We also have with us Ms. Dora Green, who is a member of the Health Equity COVID Research Advisory Board, as well as Mr. Kareem King and Ms. Chloe Miller, also both members of the Health Equity in COVID Research Advisory Board. Our goals for this evening, we really want participants as they leave the session to be able to understand different ways to conceptualize community. We also want participants to be able to provide examples of ways for of ways to power share with communities, as well as describe ways to inform policy, practice, and research through community input. As we kick off this evening, we have, I mentioned earlier, our panelists. You'll see Dr. Bisola Ojikutu, Doreen Green, Kareem King, and Chloe Miller. I'd also love to give a shout out to our CE program staff at the CTSI, Ms. Dima Hakim, who makes all of these things happen, as well as my colleague, Dr. Tracy Battaglia, the co-leader of the Community Engagement Corps, and Dr. Rebecca Laub, who is the Associate Director of the Community Engagement Corps, and Ms. Jennifer Pamphil. And I'm Linda Sprague-Martinez, I should have mentioned as well, co-director of the Community Engagement Corps with Tracy. So that being said, I think we're gonna jump into our conversation this evening. You know, a lot of times I think it's interesting as we think about the different barriers we see and inequities we see in health and well-being across our communities. A lot of times we'll hear people say this phrase that the system is broken. And in reality, systems aren't broken. We know that systems are not designed to work for everyone, but more so they're designed to work for their designers. And so that being said, we really need to think about how can we be more inclusive in who gets to design systems, who gets to decide the research questions, who gets to inform policy, and how do we make that accessible for all members of communities, particularly communities that have been historically marginalized and removed from the decision-making process as it relates to research, as it relates to health. And so tonight we're going to hear from speakers, our panelists, about ways to be more inclusive, to engage communities, particularly marginalized communities that have been marginalized through, whether it's through systematic racism, whether it's been marginalized through other systems of oppression. And so I'm really excited. Each of our speakers will introduce themselves. They'll share with you a little bit about who is community, who are the communities they're working with, and really what community means to them as they're in the context of their work. So I'll start out by turning it over to Bisola.
Good evening, everyone, and thank you for inviting me to join you this evening. So I'll start by saying that though I'm the executive director of the Boston Public Health Commission, I've spent a long period of time in academia, and one of the sort of leadership roles that I had in academia was being the director of the Community Engaged Research Program within the Harvard CFAR. So within my academic life and amongst my academic colleagues, I've often been challenged by the question of, so who exactly is community? And I've always sort of struggled there because it always seemed quite clear to me, you know, who community is and who the members are. But so I'm very careful and somewhat cautious in giving talks and being very clear about which communities I'm talking about. So for the purposes of my overall discussion and things that I'll say tonight, it's really any group of individuals, any group of people who have shared experiences, lived experiences, social relationships that unite them in ways that they define, not in any ways that anybody else necessarily defines. And I think the other piece that's always come up in discussions that I've had, again, sort of on the academic level, is really about this issue of shared geography. Like, does it have to be people who are living in a particular place or space? And none of that is the case. I think you just keep it open to individuals who are defining themselves as a unique group and who feel that there's some commonality between them. So that's how I view community. And as the Commissioner of Public Health for the City of Boston, I work with all the diverse communities around Boston. You know, I think that a lot of my work really reaches into certainly most of our most vulnerable populations, but you know, the reality is that, you know, our job as the Department of Public Health is to really engage everyone in conversation, to really bring everybody to the table. And I think later on in this discussion, I'll talk about our equitable community engagement plan and how we actually do that process, because I think it is important as we think about meeting the needs of diverse populations.
Great, thank you so much, Bisola. I'm gonna jump over next to Dora.
Said it so beautifully. I don't know if I have anything else to add, but as I can say, so my name is Dora Green, as introduced, and I am the president and the founder of Beyond Patient Health Equity. And when I think of the community, I'm referring to those who I also have along the lines have experienced that failure through the medical system. That is in the purpose of this conversation and the work that I'm doing, as well as those that I'm with here talking tonight, really who's been failed by the medical system historically, who has been underrepresented, and is looking to have a voice, have a place to make informed decisions. And so, you know, when I talk about it, I'm not limiting it to where I do focus on the BIPOC community, but it's not just a BIPOC issue, right? It extends to the LGBTQ plus community, extends to the disabled community, and so on and so forth. But collectively, what have we experienced in the healthcare system and how we can all together change that? So the community, the collective, as affectionately said in my home, that's how I would refer to it. But it's definitely people that I can relate to or I can sit with in their process.
Thank you so much, Dora. Kareem, what are your thoughts?
Yes, good evening, everyone. My name is Kareem King. I'm a third year on the pre-med track with the intention to become a future doctor. And I just want to say that I completely agree with what Dr. Ojikutu and Dora said in the way that they kind of define community. So I serve as the Community Engagement Director of We Got Us, an organization that was founded to address issues of inequity when it came to who was talking to Black communities about the vaccine and giving them their medical information. And basically being that source of trustful information that they can have in the communities. Because what we saw earlier on in the pandemic is that people were basically they didn't really know where to turn when it came to getting accurate sources of information. So when I define community, I'm talking about specifically the Black community, but also making sure that we are referencing the physical spaces that they're in. Kind of speaking to what Dora said earlier, Black people have been historically marginalized and put in places where they have less access to resources. So our organization was founded to kind of address that and also focus on those specific communities and in spaces where they don't have that kind of access. And my organization specifically focuses on Roxbury, Dorchester, and Mattapan in the city of Boston to basically like provide those resources to people of color. But we also kind of expand our organization to basically function on a national level to kind of be a place to kind of talk to our community about the vaccine and have these really candid conversations to like inspire trust in the medical institution and like be a source of amplifying their voices. So when I think of community, I think of kind of that shared communal space to talk about our issues, but also to make sure that we're sharing experiences and can really think about the best path to move forward.
Thank you so much, Kareem. Next, I'm going to turn it over to Chloe.
Yeah, thank you. Hi, everyone. My name is Chloe Miller, and I am happy to be here. I think, you know, Dora, Kareem, Dr. Ojikutu, like everything that you have said about community, I wholeheartedly agree with. And I think that community is truly such an all-encompassing word that you do have to be careful. And I feel like I kind of am coming at this idea of community a little differently than maybe some others in this group. Since I work at Project Bread, it's a statewide across Massachusetts anti-hunger organization. So we focus on lots of different communities throughout Massachusetts. It's a very diverse organization in terms of our departments. I work specifically on a daily basis with child nutrition or childhood nutrition policies, and actually talk day to day with school nutrition directors and administrators in school districts. So sometimes I feel like my day to day is very granular and very, like, my community that I talk to is this very specific school nutrition community. But in some past roles, I've worked in Boston Public Schools. I've done research at BU. So I feel like I've been through so many different kinds of communities. So I really, for the purposes of this discussion, I really am trying to focus on the idea of food insecure individuals and this kind of greater experience that is connecting so many of us in Massachusetts. And Project Bread, we've seen over the pandemic and how COVID has affected hunger and increased levels up to almost 20%. And so we work with folks in so many different levels experiencing hunger. And I think that's a really uniting force, because, food is such a uniting force. And if you're not able to meet your own needs, then we've seen a lot of folks unite around that and create a really large community of activism in terms of school food and just, better meeting everyone's needs. And food insecure individuals also are interacting in such a different way with healthcare as well. So I think it's been really important hearing what Kareem and Dora do on this community advisory board. But yeah, we really, and we also understand that Black and Brown individuals are disproportionately affected by this problem. And so I every day am learning about districts across the Eastern Mass about how they are seeing food insecurity play out differently in different communities within their own school community. So again, so many different levels, but I definitely am thinking more in terms of the experiences that unite us as a community.
Thank you so much, Chloe. So now we're going to move into just some panel Q&A, and I would encourage folks, as you're listening, please throw your questions in the chat. We'll pull from the chat, and we have an open Q&A session a little bit into the panel. We just wanted to start with folks thinking about, we're talking about research, policy, and practice to advance equity. Maybe we can start out just by reflecting on what are some experiences that you've had with researchers and research community partnerships, particularly by way of, as you think about decision making and community engagement and decision making around research. And I'll throw that out to the panel. I don't know if anyone wants to start.
I can go first.
Thanks, Kareem.
So We Got Us, as I kind of said earlier, we were founded in January 2021. And our goal from the beginning has been to think about ways to integrate community input into all of the programs that we host as an organization. So one of the ways that we kind of interacted with research and with community in that way has been to make sure that we're partnering with them from the very beginning with any of the programs we roll out, and also making sure that we're getting their feedback when it comes to how the programs are impacting them and ways to improve it. So past research projects that we've done as part of our organization have been partnering with local churches to basically interview church members about their experiences with COVID-19, what they're going through right now when it comes to food insecurity or housing insecurity, how their kids and their children are being affected by being at home during the pandemic, and internet barriers, things like that. So really making sure that our research is integrated into that and kind of addressing the barriers that they face. And also making sure that we're partnering with community members and local activists to be a part of that. So just thinking about one example, we partnered with Housing Equals Health very early on as an organization to basically do outreach with the homeless. And we found that their experience is really valuable in thinking about how we can address this issue and what we can best do to basically help the people in this population. So just making sure that community input is an integral part of the way that you approach research, and also the kinds of programs and impact that you want to have on the community.
Thank you so much, Kareem. Are there other panelists would like to share examples?
Yes, I'm sorry, Linda. You're so soft spoken, so I was trouble hearing you. But with Beyond Patient Health Equity, and forgive me for not letting you all know exactly what we do. So our our intent is equitable healthcare by means of equitable research. And that's engaging through three pillars, which we engage the community, educate them, and then empower them to make informed decisions that are going to impact generations to come. And what that looks like is that we have our hands in everything. Most recently, we gave 2 different workshops to 2 different organizations, one to a higher education organization talking about health equity and really educating these future clinicians or providers, if you will, because it was a multidiscipline educational institution. And so everyone that was in attendance had different disciplines that they were going to be working in as providers, encouraging them to step out their comfort level when it comes to discussing what is clinical research and why you should engage the patient that you would consider a loss to follow up, or may not be continuously engaged in healthcare, and why that's important and how that impacts not just them, but future patients, your practice, so on and so forth. The other workshop that we gave was to a pharmaceutical company. And that company is in their infancy, and really having the opportunity to have a conversation with them to help them work through, not only did we provide education about health equity, the history of the malpractice of clinical trials and eugenics, so forth within the United States, but also helping them come to a consensus and defining collectively what health equity meant to them as an organization, how they can integrate that into the fabric of what they're doing in their pipeline of drug development, and how they can hold the organizations accountable that they're working with for recruitment of patients. So there are a lot of misconceptions, and there's a lot of steps that the community is just not involved in. And so those are some of the things that we're doing within Beyond, as well as putting on different panel discussions similar to this. This is a shameless plug. We have an event coming up next week called Black Health, Black Genetics. And it's a series of event, and it's discussing really the intersection between clinical trials, genetic testing, screening, the diagnostic odyssey of a patient, and what the barriers might be in that process where the community can be involved, right? We're in essence asking the community to participate in clinical trials, and we are still utilizing the same protocols that have historically been extractive, harmful to us. And so if the definition of insanity, I'm sure everyone's familiar, we're approaching it with the same approach and expecting a different response, which doesn't make sense. And so we're encouraging different organizations, whether they be healthcare institutions, whether they be patient advocacy groups, because sometimes they don't even look, they are just accepting the collective that are coming to them that want to join. But there's access barriers as well within that. If there's a patient advocacy group that I'm aware of, how did I become aware of it? Online? Well, what about the patients that don't have data or internet? So thinking about those groups and higher education, and where we can interface with other groups like We Got Us, or with the state or federal groups, or even pharmaceutical, the industry, really trying to occupy every space and have that conversation, help better define health equity as it pertains to their practice and the focus that they're doing, and why they emphasizing why and the impact that we can have if we're able to be more inclusive and intentional in our approach in inviting the community to be involved in every part of the process of improving their health outcomes.
I love your example, Dora, of the definition of insanity. So often we keep doing the same thing over and over again and expecting a different answer. And then we say things like those hard to reach populations, when really their populations are hardly reached because we keep doing things that work for us as opposed to things that work for communities. So I really appreciate that example. Bisola, you had come off mute the last time, so I'm going to turn it over to you. I'm using my loud parenting voice right now.
No, I can hear you, but it seems like you're a little soft spoken. I get the sense that you're not necessarily. So, I did want to mention that question that you asked, sort of, and what Kareem and Dora both mentioned, sort of made me think about structural racism and how it manifests in research, just in general, irrespective of what the research is that it's occurring. You know, when you think about structural racism and you think about, you know, systems of hierarchy, privilege, and power that excludes non-white individuals, and you think about particularly the issue of power and how, you know, people of color oftentimes don't have power in regards to getting funding to do research, engaging in research, putting research questions on the table to be, assessed or looked into. It becomes this process that I think that we really need to look at more closely. And I think that there are people, it feels that there are people who are interested in that dynamic, but not really, because it means losing power. You know, if you shift that power dynamic and you no longer are getting the funding, you're really turning our system upside down. And then what does that mean for the system? And you mentioned, Linda, that the systems aren't broken. They were created for the people who are benefiting from those systems. So now you're telling people, well, let's dismantle structural racism, but let's really pull it apart. What does that really mean to people? Do we really want to dismantle structural racism? I mean, do we really want to shift decision-making power? Do we really want to shift resources into the people who, you know, would benefit in ways that would really promote health equity? So I put that out there more as a question, sort of, or a thought to the group. It's something that I sort of constantly think about, because as we talk about using that word dismantle something, you're dismantling something that a lot of people benefit from. So.
An important piece, and that's what makes it so scary for folks, right? That's why we don't have these conversations, because there's something to lose. But at the same time, there's something to gain, because racism hurts all people. It doesn't just hurt people of color. Kareem, you came off mute, so I'm turning it over to you.
I just wanted to add one thing that kind of brought to mind for me in Dr. Ojikutu's description of like how structural racism operates to basically prevent certain research questions from even being explored in the first place. Thinking back to kind of the infrastructure of research in the medical institution, I read a study recently that showed that over 20% of less than 20% of papers actually even reference racism to begin with. And that's something that's like is a big driver of kind of a lot of the health inequities that we see in communities of color. But they'll reference other things like environment or underlying health issues, but they won't really explore like what that actually means when it comes to what these underlying health issues stem from. Thinking about the resource that people are given at birth, their access to like healthy foods, the kinds of education that they get, and the kinds of neighborhoods that they're relegated to. And all these things really play an integral part in this conversation about how underlying health issues arise before people even get to the hospital, but it's not something that's traditionally explored in research. And another thing you brought up for me too is the fact that like research conferences, for example, where you kind of go to give, to basically present on research and kind of like interact with the broader academic institution. These are conferences that traditionally you have to like pay a fee to even register for, and it costs a lot for people to actually even go to present their projects. So if you're already dealing with this underlying issue of research that's in this particular area, like racism not being funded, and then you have these things on top of it, like having to pay to present your research and paying to like be in certain spaces where you can amplify that research to other people, potentially get even more funding to fund it. That's just like some of the ways that we kind of see these underlying systems of inequity operating to prevent these topics from ever being explored in the first place. So I just wanted to bring that point there.
Great point. Chloe?
Yeah, I just want to say that was a great point, Kareem. I think a really great way to sum up what Dora and Dr. Ojikutu is saying. But, you know, that brought up for me, like the work that I do is really, I am hoping to base my life off focusing on those, you know, underlying causes of health inequities and underlying causes of negative health outcomes. And you know, I'm also, my day job is project grad, but my night job is I'm a student at the BU School of Public Health. And I think being in these two worlds of like academia versus a community facing public organization, I really see the differences in how like researchers talk. And then when I go to my day job, it's like how communities talk. And I think there is something very different about those kind of silos and the language. Literally, it's like you're speaking a different language when you're talking to someone who's doing academic research on the social determinants of health, but we call it the social determinants of health rather than saying racism or, like these underlying causes of what is actually operating in our structures and making, and why these structures were designed this way. We say food insecurity, we don't say food apartheid, but it really is. We have redlined communities and relegated them to communities with lower resources, and then we say it's like a food desert as if it were natural, and it's not. It's by design. So I think it's really important to kind of combine the way that people experience their everyday life and Black and brown folks and Black and brown communities that I talk to every day. It's like, again, really trying to bring that language, that experience, that everyday lived experience into the silo of academic research to kind of mold those two and meet in the middle somewhere. And I think it's really important to actually naming and furthering the research and figuring out solutions and hopefully kind of dismantling or changing that system to better meet all the needs of all communities.
Really great points all around. And I love that you've highlighted this idea that the social determinants of health, which we're very comfortable talking about, only matter because we live in a racialized society, right? If we didn't live in a society that was racialized and where we had racial capitalism, the whole idea of social determinants, it would play out very differently. But that coded language, it has an impact when we don't name what it really is. I'm going to jump us to think about, given we know that the answer is engaging people, we know that the answer is turning the system upside down, as Bisola points out. How do we do that? What are some strategies that you all have found effective in engaging communities in research, engaging communities in program design, policy making? What works for folks? Should I call on someone to start? Thanks, Dora, for coming on.
I'll go
I didn't want to
first.
have to call you all out. But,
I believe having those uncomfortable conversations. So in my day job, or I shouldn't say day job because I do both simultaneously, but I also work in the pharmaceutical industry. And in there, I've had the privilege to take on a health equity role. And I'm put in front of these different people. And in that role, I'm having these uncomfortable conversations about truth and reconciliation. And some people are ready to have that conversation. Others aren't. The biggest thing that I've recognized in this process is that it's a journey for everyone. Same thing when we're giving our workshops at different organizations, it's a journey. So the higher education institution that I had referenced earlier, they were prepared to have this conversation. They were asking me questions, challenging my ideals, which I loved. Whereas the other pharmaceutical company that I had worked with was, still throwing out ideas and trying to get their task force together. So I think the biggest thing is understanding that everyone's in a different space of the journey. Regardless, we do need to name it, right? We need to name that this is racist, this is structural racism being played out. And we need to recognize our parts, right? The impact of power, of racism, power, privilege, and positionality plays a big role as individuals, but as a collective unit, whether we're in an organization or we're working as a nonprofit, wherever we're working to make this impact. But we need to be willing to really occupy that space and have the conversation, to be the one to start to answer the question first, really, and to point out areas that are going to push the envelope and wait for the no's or maybes or soon enough, but continue having that conversation on a consistent basis.
Thank you, Dora. Other folks, strategies for engaging communities in research, maybe strategies for engaging communities in policy and practice. Kareem?
Yes. So going off of Dora's point, I think one of the best ways that we can kind of work with communities to basically kind of drive this research is to make sure that we're making questions that address the issues that community members face. So thinking about like going back to the very beginning before the question is even framed, how will this affect the community that we're actually trying to research? What are the benefits that could be had for them? And also, how could this research possibly improve their lives and like their livelihoods? So I think one of the best ways that we can kind of integrate community input is by making sure that they're involved from the very beginning. So when we're going out to the communities, who are we talking to basically like gather our information? What are their thoughts and how are they being incorporated into the research process and the questions that we're developing? Where are we actually going to actually do this research when it comes to community spaces? Thinking about whether we're going to places like public transit or like going to like community like playgrounds, things like that. Kind of where are we going to basically engage with people and how are we doing that engagement? Is it something that is open to everyone, or are there certain barriers that exist to make sure that everyone can participate? Thinking about things like time constraints, like who's actually able to participate in research, making sure that we're providing for things like language barriers, and also that we're providing for people who might not be that might not necessarily like be trustful of the research institution. How are we being thoughtful around those different issues and working to make sure that people feel comfortable in this space and that we're actually making research a place where they can actually provide their input and see it be implemented into their own communities. So I think that's one of the best ways we can do that, is by making sure that the research questions we're asking are really getting at the community issues and that we're actually seeing people as people in this research process.
Excellent points.
I wanted to piggyback off of what Kareem had just said. Where are we going? And that is something so simple that we overlook. Like, we never think to bring the research to the community. It's always come to us. And that in itself has its own barriers, but being able to come to the place where the community is that we're trying to seek out, it breaks down a whole nother level of barriers. Our past event this past summer, we had an organization that was enrolling patients into clinical trials at our Back to Health event that we partnered with We Got Us on. And in that event, they had 45 people who had, they historically have not been able to recruit. So this was people of different ethnic backgrounds joining for the study. About 22 of them had followed up afterwards. And that was a large number of people. And this isn't a healthy people study. And it was part of bringing the clinical trials, creating that normalcy of them being present in that environment, and so that they can explain who they are, what they're doing in their own format, and that the community can make that decision. Maybe I will, maybe I'll follow up, maybe not. But it's the opportunity to provide that information. I think there's a misconception that the communities that we're referencing that have been disproportionately impacted by negative health outcomes, that they don't have an understanding of what research is or the importance of it. They understand. They have full understanding. Doesn't matter their educational background. The problem is that we're not being intentional in how we're approaching them. And that actually means approaching them face to face, and having that conversation, as Kareem referenced.
Hearing that human side of it, like meeting people where they're at and talking to them as though they're humans, right? They're our neighbors, they're our families. Right? Bisola, you had come off mute before, so I'm gonna jump over to you. Did you have a point as well that you wanted to share?
I just wanted to mention that one of my frustrations, during, throughout the pandemic, has been this desire, sort of promotion of community outreach, to get things done and to get it done quickly, whether it be my academic sort of, colleague folks who want to enroll people in studies and recruit, or for programs and to engage them in community advisory boards or whatever. It's been this very unidirectional process where it's focused on a very limited goal. You know, it's meant to get something done, and to get it done quickly. It's not done it with intentionality. It's not necessarily involving people from those communities per se. It's not about long-term collaboration or true partnership or, you know, real investment and capacity building within communities. Like Dora was mentioning, you know, people know a lot about research. They want to know more, particularly now. You know, they really, you know, I've noticed there's just been a lot of, you know, craving for knowledge about COVID-19, about other things. You know, I think that's sort of has happened, which has been a great outcome of this experience that we've all sort of, you know, gone through. But I think that for a variety of different reasons, our system is set up to support outreach, and it's not established and set up to support real equitable community engagement and investment in communities so that they can really truly be partners in the work that we do. So that's a frustration, and I think everything that Kareem and Dora have said about how to do this well feeds into that. But I think that it's really, you know, part of what we need to do to change the system that sort of set this up. Even in the setting of emergencies, we don't have to resort to just sort of, you know, reaching in to take. You know, we need to reach in and leave behind and actually build capacity for the future.
Great
Oh,
point.
sorry, Linda.
No, I was just going to say a great point, because we don't behave that way in all communities. I just think naming that whole idea of outreach and taking, that we're comfortable behaving that way oftentimes in communities of color, but we don't behave that way in upper middle class white communities. And so I think that's an important thing to keep in mind. Chloe, go ahead.
Again, beautiful way to say it. I think I was going to say pretty much the same thing. I think in not just my work at Project Bread, but, you know, my previous work I was a researcher at BU. I've worked in Boston Public Schools, and I think one of the things I noticed is I think there's a lack of people asking themselves, or researchers specifically asking themselves, or just programs and, you know, wonderful people who are with the intent of, you know, giving back or learning more, or whatever it may be. They have this end goal or end in mind. And I see that oftentimes there's not really a question of why are we in this community, and what is this going to how are we specifically going to impact this community? Like, why are we researching a community of color, or a Boston Public School versus a Cambridge Public School, or whatever that may be? And, you know, like Linda and like Bisola, we both have touched on, like, we often see this kind of extractive behavior in these communities of color. And I think I just kind of, one of my frustrations is that there's not really this question or a process of having researchers really choose intentional communities that are best fit for their work, and in that way not having community voice inform questions, not having community voice inform the outcome of that research. I think those would both better match communities to certain research. And then, you know, the same kind of way, maybe providing compensation, and in a better way, not just maybe financially, which, though that can be very helpful for many. I think there's also the idea of like expanded compensation, of reconciliation, of a general partnership that's going to create sustainability, that is actually going to last and present solutions that a community is hoping for, you know, or create systems in that community to rebuild and reconcile. You know, there needs to be a bigger idea of how we're connecting to folks and how we're compensating them for, you know, extracting from them, really, so we can make it a better and more balanced two-way process.
Thank you, Chloe. I wonder, Bisola, I know that you all have been doing a lot of work around an equitable community engagement plan, and I wonder if you would be willing to share with us a little bit about that plan, just as an example of thinking about, what does this really look like? What does it mean not to be extractive? What does it mean to have these bi-directional dialogues with communities and really be working in partnership and to be in relationship with communities? Oh, you're on mute still.
I really appreciate the opportunity to talk about this. I think one of the principles that should be, sort of the foundation of any public health department is that we, engage in equitable partnerships, in equitable collaborations with our communities. And I think that it's hard sometimes because of the models, that we just talked about, that we've seen, that it doesn't happen. Even if we wanted to, it doesn't happen the way that we'd like to. I mean, we all know, we get grant funding and then we just got to get it out the door. We got to go run and go do it. And then there isn't that time to process and to figure out who, how to even approach, if that's the direction it's going in, because that's I think part of this is that if we're the ones who are getting the money and we're the ones who are engaging in this process, then how is it that we are approaching the right partners in community in a way that's equitable, and yet getting out the way and letting them then lead the process? Systems don't generally do that. That's not how systems and institutions are really designed. But so essentially, the Boston Public Health Commission developed this equitable community engagement plan, and I can put it in the chat. But the idea is that it's basically giving people a framework, okay? And the framework really rests on a number of different principles that I really hold true, like accountability and transparency and open communication and all the things that I think are really key as you develop, partnerships with people, true, authentic partnerships with people. But I think this idea that I appreciate, one idea that I appreciate out of this plan, because it did precede me, is that it highlights the fact that these types of engagements can and should be originating from communities. It's not always the Department of Public Health or the, Harvard or BU or whatever. The funding stream can legitimately go into community. It doesn't always need to go as a conduit, through these other institutions. And we don't need to assume that there's some higher risk per se, by putting it into community first. And understanding that community in many ways and through many different coalitions, the systems and development and coalitions that have been developed can manage, these resources. And what we're doing is saying that we encourage that community-led and driven projects then be brought back to us, inform us about what the issue is, what the strategy is that we want to interact on, and maybe we have more resources. Maybe we have somebody in our research evaluation office, in our informatics office over here who has all the expertise in regards to, say, measuring, food insecurity and other things that we may have, collaborating equally. And at the same time, it's not like it's a one-way process, but exchanging, what I mean? So we're giving information, they're bringing something to the table, and there's the end result being that the community walks away having gained not only whatever the project is, whatever the program is, but also this issue of capacity. Because I think it's been frustrating to me over the years doing this work that we don't always see sustainable capacity being developed. The problem goes away and the relationship goes away, and then that's it. And we're back at, square one, somebody's coming in to start all over again. But really having capacity that's being built through this process of equitable community engagement. So I welcome, you all's, taking a look at the plan and letting me know by email or whatever. We can, talk about it more if there are strategies in there that you think are useful or that you think need to be updated. Because like I said, the plan, I think it was written in 2019. It's from 2020 to 2023. And we as the Boston Public Health Commission actually need to update our equitable community engagement plan every 3 years or so. So literally it's a process that's always an evolution, which I think is great because new theories, new thoughts, new ways of doing things should be made available and thought about in terms of how we approach and engage our communities.
Wonderful, great. I think it's refreshing because we know that people know what they need and we don't need to tell them what they need. So the idea of really being in relationship with folks and communities, and the point that you made also about the money goes away, the partnership goes away. Well, don't relationships withstand beyond dollars? Like that tells a story. So great. I'm wondering if there are any final comments from the panelists before we turn it over to the audience.
I I did have one more comment, and this is just speaking to Dr. Ojikutu's point about capacity and sustainability in communities. So I think one of the things, like she said, that traditionally gets missed in these research topics and also these research pursuits is this idea of how do we make sustainable changes to communities and how do we involve them and basically like work with them to make those changes. And just to give an example, one of the things that We Got Us has been really focused on in the last few months has been working with housing inequities and thinking about how people who are unhoused can essentially like get access to resources. And recently we worked with two organizations, Massachusetts Union of the Homeless and also Housing Equals Health, to apply for an NIH grant to basically like provide resources to the homeless. And after receiving that grant, we basically partnering with these community members to continue that research over the next year and making sure that founders and local activists on that board are a part of the principal team. Right now, we actually have one of our co-PIs being from one of those organizations. So making sure that they're really a partner from the very beginning and that it goes top down and not bottom up in the way that we're kind of thinking about this and working to create sustainable changes in communities. So yes, thank you for making that point, Dr. Ojikutu.
Great, and a great example. Thank you, Kareem. We have a question in the chat from Tracy Battaglia who would love to hear you all talk a little bit about some strategies to help us hold each other accountable in this work. Like how do we, and Tracy, chime in if you want to come off.
I think, you captured it well. I think we've heard from several of the panelists about our frustration about sort of the means to the end. And, I think we're making so much progress. The fact that we're even having this discussion this evening and we have 44 participants, listening in after hours is a testament to progress. Our experience as a community engagement team is also frustrating at times in building capacity of our partners who really want to learn how to do this, but they slip back to their usual ways because the systems are designed for the usual ways. And so I think our program specifically would really benefit from hearing from your wisdom about how do we help hold each other accountable so that we really do continue to sort of push this work forward and don't just talk about it, but actually act on it.
So I'll make one comment. I really highly suggest that the funding streams be tied to doing this right. I think that there has to be something that's tangible that people will lose. It's not that I don't think that there's good intention, but I think what you said is really important, that the system isn't designed to do this. The system is designed to do, like we were describing, sort of the outreach and the, sort of transitional sort of or temporary sort of activities that when the funding's gone, then the program is over. It's almost like the accountability piece has to be built into the funding that's received. And that's my thought. And again, maybe it's also my thought because I'm thinking about some RFPs that we're thinking about pulling together and what it is we want, to include as key, sort of determinants that will dictate who actually gets funded. And we want to see that. We want to see what's your plan for sustainability. What happens after this X amount of dollars is done? Who is actually going to be your partner and what is their capacity right now? And how are you building capacity with those particular people? So that's one thought, but I think that, it's something to think about to sort of trigger changing the system.
Great point.
I'll add to that. I resonate with all the comments in regards to sustainability, and this is a hope of mine to see with the organizations, and a suggestion that I make to most of the organizations that I work with internally and externally, that we should create a space for the projects that are existing or the clinical trials that are anticipated. First, it should be so the funding. I think it was mentioned briefly that many organizations will have funding, and once they get the funding, the clock starts, and that can happen in the pharmaceutical setting as well as in the academia setting. you don't have much time to do all the intentional things. And that's just that's that is the response, but it's not enough. We have to be intentional in having a preemptive rubric that we're following along. And what that rubric, I believe, should include, do you have a community research assistant? And what does that look like, that revolving door, so that they can have that pathway or pipeline of different community members joining in, adding in their input, right? Meeting of minds, meeting of experts on the community as well as on the evidence-based medicine or science that we're utilizing to conduct this research. But really, again, I agree completely with Dr. Ojikutu, which is it has to be tied to the funding, and then what is the really understanding what the post study, what does that look like? Because if you're studying me for my disease state and there's no plan to continue with me or to tell me what's next after the study's done, that relationship that has been cultivated, that trust that has been cultivated should continue, because my disease continues, right? Or my condition continues, and it continues to impact my community or collectively the generations to come if it's hereditary. So what does that look like? Having that conversation preemptively prior to getting the funding, or if that's a part of getting the funding, the organizations that are giving the funding, that's something that they should be holding other research groups accountable for.
Great point. And Chloe, go ahead.
Yeah, I just wanted to jump off Dora's point about kind of that institutional accountability, where I think I really agree that like some of the work that we were doing on the community advisory board has to do with that. And I just want to kind of mention 2 points. So I think that, funding is one intensely scary topic for a lot of folks in research and programs, and I think it is like probably one of the best ways to keep people accountable. And I think another way that we can do that on more of a research side of things is really making sure that our IRB is mixing in community engagement and equity into their institutional requirements. Like, we don't need to just give researchers money and then approve studies and go. Institutions need to be held accountable to hold their researchers more accountable, and organizations, the same way that organizations are held accountable to keep their employees accountable and on point. So institutions are the ones reviewing this research, and they need to make sure, whether it's using some kind of health equity rubric or some kind of systems change, that researchers are meeting all the needs of the communities. Researchers have a plan for both, building health equity into their design, building community into their design, whether it's a literal person on their team who's helping with that, or they have processes and methods that are going to be built in. And then I think beyond that, we also have to have the thought and intentionality into how are we going to communicate the impact of this research. If it's meant to be positive for a community, we need to make sure that our evaluative systems at an IRB level or research level are actually evaluating for effectiveness and then communication and sustainability and capacity in the community that we are hoping to affect, right? It can't just be like the research gets done, the paper gets written, the researcher goes. And I think there's a lot of ways to do this, and I might be talking on a more general level, but I think, sustainability, I definitely agree with everyone's points about it. It's key.
Well, we'll end on those wide words of wisdom from Chloe Miller, and that our systems, we need to hold our systems accountable, and systems change within, and think about how they get in the way, and what we can do to improve them. I want to thank you all for staying with us. This 60 minutes goes by so fast. I have quick wrap up announcements that please be on the lookout. It is March. Welcome to March. We have our next panel, how we all win, community science and environmental justice. We're going to hear from the CAFE, Community Assessment of Freeway Exposure and Health Partnership. It's a partnership that started with a community question in Somerville and led, and that was back in 2006, 2007. And all these years later, a number of studies that are all led in partnership by community members and researchers out of a number of different universities. And so we'll hear from them next month. We also, later this month, we also have on the 17th, our networking at noon session. So if you want to come and talk about some of these hard issues, join us. We're going to be really thinking about how we communicate and engage with one another in partnerships this month. And so we welcome you to check out our website, come to the events. It's a great way to meet other folks who are doing community engaged research, other folks who are interested in changing the way we do research and changing the way we work together to really disrupt injustices. And so we look forward to seeing you. Did I miss anything, Dima? All right, I think I got it all. So we'll stay, yeah. Thank you so much to our panelists also. Great conversation.